We are in Chicago, as you can see, for ACC 16. And part of our coverage here is looking at the idea of comorbidities. If you live long enough, you're going to have several of them. In this particular case, we're looking at major bleeding among Rivaroxaban users with non-valvular AF and diabetes. And to talk about this, I'm with Frank Peacock, who is an MD and professor of emergency medicine at Baylor College of Medicine in Houston, and the chief of emergency medicine research there. First off, thank you very much. What is this particular trial that you're talking about?
So this is a post-marketing surveillance analysis of about 50,000 patients' data. It comes from the Department of Defense data set, so it's not, people think that's the Veterans Administration's, it's not. This is actually an insurance company that provides coverage for all the people, so it's in the Department of Defense. So it's 50% women, they're old people, there's young people, it's not the stereotype of the veterans. And we looked at all those patients in that subset who were on Rivaroxaban and had diabetes and atrial fibrillation. And the reason to do this is because if you think about the CHAD score, if you have, the D is diabetes. And so as a subset, this is a big player in outcomes. The other thing about the CHAD score is the higher your score, the more likely you are to bleed. So the higher your score, the more likely you are to stroke. And so that you have to balance those risks. And so we've actually done that analysis as well. The stroke always is worse than the bleed rate, but we wanted to look at it specifically with diabetics, because diabetics have other issues, renal failure and those sort of things. So that's what we did, is we subsetted that out. We started with 50,000 patients who all had AFib and were on Rivaroxaban, and we ended up with about a third of them that had diabetes also. It's 27%, so it's a big number. And that's what this analysis is. So what we found is diabetics bleed a little bit more than non-diabetics. The rate of major bleeding, and that's got a transfusion, had to be in the hospital, lost a couple units of blood, the definition of major bleeding. Those folks having about 2.5 per every 100 patient years, and the normals and the diabetics, it's 3.5. Now we do it by 100 patient years. This becomes important when we start comparing this to stroke risk and that sort of stuff. So it's per 100 patient years, 3.5 diabetics will bleed. And the reason you do that is because somebody who's on Rivaroxaban for 4 weeks is way different than somebody who's on for 15 months.
True.
So it standardizes the exposure risk. And then when you start looking at those bleed rates and breaking them down, they look very much like all the randomized controlled trials. So like all the NOACs, the patients who have a bleed rate in this group, in the diabetics, more likely to be GI than anything else, overwhelmingly. And there was an increased risk of GI bleeding in the diabetics. It's not huge, but it's about 1 per 100 patient years. But intracranial hemorrhage is the same, other bleeding is the same. And the fatality rate associated with this is remarkably low, and there was no differences in fatalities between the diabetics and non-diabetics, and it's 0.09 per 100 patient years. So if you round that off, it comes 1/10 of a patient per 100 years will have a fatal bleed. And I always put this in context of stroke, because docs get all worried that they don't want to give somebody a drug that's going to make them bleed. But remember, what we're doing is we're preventing strokes. If you have a CHAD score of 2, so you're an old guy with AFib, and you have diabetes, the risk of stroke next year is 3%. That's 3 per 1 year. That's 30 per decade. That's 300 per 100 years. So if you do the math and say, I'm scared to put a patient on an anticoagulant because they might bleed, well, you're going to save 0.1 per 100 years of patients, but you're going to give 300 people a stroke. And the numbers are so overwhelming when you start putting them on the same exposure risk basis that I think it's sort of a no-brainer.
So this really is encouraging.
Yeah, this is very satisfying and reassuring that when you have somebody who's got AFib and diabetes, that they should be on an anticoagulant.
Is there anything you wanted to say in terms of risk? Is there any patient where you would be nervous about putting them on who's diabetic, or is it just pretty much by itself, this should be a safe approach for a patient with diabetes?
Yeah,
type 1 and type 2, for example, is there a difference?
Didn't split types out,
Okay.
but I would tell you this, that the higher your CHAD score is, the more likely you are to bleed. And the bleed rates become significant. However, the stroke rate is always monsterly higher than the bleed rate. So you give it to somebody with a CHADS of 4, they have a measurable bleed rate, but they have a huge stroke rate. And so part of your job as a doc is to do risk-benefit analyses. And so the risk-benefit analysis here is really clear. an advantage of a post-marketing surveillance study is it's real world. You know, in a randomized controlled trial, you've sliced it down so you only have people who are a certain age with a certain number of comorbidities, and they're all pretty compliant because they're in a trial. And you go out to the real world, it's a mess because, you know, you got people who can't remember to take their drug. Sometimes they take an extra drug. They have 4 diseases. They didn't tell you about the other things they're taking. You know, on the side they do a little cocaine and some St. John's wort. But that's the real world, and so when you get this data in real world, it's really reassuring that the safety margin is the same as it was in the randomized controlled trials.
Well, please look around for the rest of our coverage from ACC 16 for CardioSource World News and CardioSource World News Interventions. I'm Rick McGuire.